An elderly patient arrives at an emergency department covered in bruises. The trainee doctor, ambulance nurse, and emergency department nurse all express concern. With consent from the legal representative, a safeguarding report is filed. Later, the patient files a complaint, not against the trainee who filed the report, but against a senior specialist who was simply on call that day. She says no one contacted her GP and the report was based on surface level information. And the case goes to court. And what was the ruling? The consultant is cleared. He wasn't involved in filing the report and didn't see the patient until after admission. And here are some key lessons for healthcare professionals. Number one, safeguarding must be thorough. Surface level impressions aren't enough, and you need to speak to the general practitioner if possible. Timing matters. If the patient will be admitted, there may be time to gather more information. Number three, consent and communication are critical. Always disclose to the patient when a safeguarding report is made, if safe to do so. Number four, responsibility must be clear. Just being on call doesn't mean you're liable for team decisions. Safeguarding is essential, but it must be balanced with proper process and patient centered care. Follow for more real life court cases in medicine. A patient with a history of heart disease, diabetes, and obesity visits his cardiologist complaining of chest pain. His general practitioner refers him back several times, urging further investigation. But the cardiologist thinks it's gastric. An MRI is done, there's no signs of ischemia. There's no coronary angiogram ordered. And over the next few years, the patient visits multiple times with worsening symptoms. Eventually, a second cardiologist does order an angiogram. It reveals a severe blockage, and a stent is planned. But the patient unfortunately dies before the procedure. The family sues the first cardiologist for negligence, and the court rules in their favor. What are the key lessons here for health professionals? Number one, never underestimate high risk patients. Atypical chest pain in diabetics can still signal serious cardiac issues. Number two, follow up with proper investigations. MRI alone isn't enough. A coronary angiogram may be essential. Number three, communicate with GPs. Failing to send regular updates damages care continuity and your legal defense. Number four, document everything. If you choose not to follow a guideline, explain why and document the decisions. This ruling wasn't about a single mistake, it was about years of missed opportunities. Follow for more real court cases that challenge how we practice medicine. A psychiatrist prescribes a low dose of quetiapine to help a patient with severe anxiety and insomnia. The drug is typically used for psychosis, but in this case, it's used off label. The patient agrees to the treatment after being informed of its purpose and potential side effects. And weeks later, he attempts suicide twice and blames the medication. He files a formal complaint accusing the psychiatrist of negligence. The disciplinary board reviews the case and finds off label use was appropriate, informed consent was documented, monitoring was consistent, no clear link between the medication and the suicide attempts. The psychiatrist is cleared. What's the takeaway for us doctors here? Number one, off label prescribing is common but must be justified and documented. Number two, informed consent is essential. Explain the purpose, the risks, and alternatives. Number three, document discussions clearly in the patient record. Number four, monitor patients closely, especially those at high risk. In this case, off-label use wasn't the issue. It was poor communication and documentation. Follow for more real-life cases where doctors are brought to court and what we can learn from them. A psychologist is asked by the court to assess a patient's mental health as part of a criminal case. The patient refuses to cooperate, but still the psychologist submits a report that's based on prior records and family input. Years later, the patient files a complaint. He accuses the psychologist of bias, intimidation, and reaching conclusions without a fair assessment. So it comes to the disciplinary board attention and they investigate further. What do they find? Family input was appropriate given the patient's refusal to participate. The report acknowledged its limitations, and there was no evidence of ridicule, personal bias, or misconduct. The recommendation for this to be done followed professional standards. The psychologist is cleared. What's the main takeaway for doctors in this case? First of all, forensic evaluations can proceed even without patient cooperation, but limitations must be clearly stated. Secondly, using collateral sources like family is valid when direct input is missing. Thirdly, documentation must be transparent, neutral, and structured. Fourth, accusations of bias often stem from miscommunication, so you need to maintain professionalism at every step. This case shows the weight psychologists carry in legal settings and how objectivity protects both patient rights and professional integrity. A psychiatrist receives an unsettling email from an email. It references a recent mass shooting, and the shooter's background matches the patient's. The psychiatrist feels alarmed. She consults colleagues, then anonymously contacts the police. Eventually, she discloses the patient's identity, and his firearms are seized. The patient files a complaint. He accuses her of breaching confidentiality and reporting false information. The disciplinary board steps in and they rule the psychiatrist acted out of genuine concern for public safety. She followed appropriate consultation steps. The perceived threat was reasonable. Disclosure was limited and accurate. The psychiatrist is cleared. So, what are the takeaways for healthcare professionals in this case? 1. Patient confidentiality can be overridden, but only when there's a serious and credible threat. 2. Always consult colleagues or legal advisors before breaching confidentiality. 3. Document every step in your decision making process. And 4. Share only what's necessary, never more than what's needed. In this case, even when the law is unclear, professionalism, process, and documentation are going to be your best defense. An elderly nursing home resident shows signs of fluid retention and shortness of breath. The daughter urges the geriatric specialist to hospitalize her mother, and the specialist examines the patient. Vitals are stable, mental status is clear. He then prescribes diuretics but decides against hospital admission. The patient deteriorates a few days later and is hospitalized, but she then passes away. Her daughter files a complaint. She accuses the doctor of negligence, poor communication, and being dismissive. It goes to court, and the disciplinary board have to investigate. So, what did they find? The clinical assessment at the time supported outpatient management. Documentation of vitals and decision making was sufficient. Communication could have been more sensitive, but intentions were not harmful. And this doctor is cleared of all allegations. What are the main takeaways for doctors like myself? First of all, in elderly care, clinical judgment must be balanced with family concerns. Clear documentation protects you when outcomes are poor. And one of the third takeaways is communication with families should be empathetic, especially when it comes to end of life care. The fourth takeaway is always explain your reasoning, even when the decision is not what the family expects. And this case highlights how emotional dynamics in elderly care can lead to complaints, even when the care is appropriate at the time. A young adult with severe mental health issues receives systemic therapy from a psychologist. Her mother wants to be more involved, but the patient repeatedly refuses. Over time, her condition worsens. She's hospitalized, later discharged, and eventually she dies by suicide. Her mother files a complaint. She believes the psychologist failed to involve her in treatment, which could have saved her daughter's life. The psychologist defends his care. He made repeated efforts to involve the mother. The patient, as a competent adult, explicitly denied, and all decisions and refusals were documented. And the disciplinary board in this case agrees. They find no negligence and even rule the complaint inadmissible, as it contradicted the patient's known wishes. What's the main takeaway for healthcare professionals? First of all, patient autonomy must be respected even in complex mental health cases. And secondly, family involvement is valuable, but only with patient consent. Thirdly, document every attempt to involve family and even every refusal for their involvement. Number four, a tragic outcome doesn't always mean wrongdoing. And this case is a reminder that honoring a patient's choices is both ethically and legally necessary, even when the consequences are heartbreaking. The patient undergoes surgery for shoulder pain. He later claims the diagnosis was wrong, the surgery was unnecessary, and the procedure was poorly performed. He sues the orthopedic surgeon for malpractice. The surgeon had diagnosed biceps tendinopathy after failed conservative treatments. The patient consented to a tenotomy, which is a low risk procedure, knowing the risks. Post-operatively, the patient develops a frozen shoulder and continues to experience pain. He believes it was a rushed surgery and demands compensation. So it goes to court, and the disciplinary board starts to investigate. And what is it that they find? They find the diagnosis and treatment plan followed acceptable guidelines. Informed consent was very clear and it was documented. Post-operative complications like a frozen shoulder are known risks, and it doesn't necessarily mean the doctor was being negligent. And there was no evidence of surgical error or improper care. The surgeon in this case is cleared of all wrongdoing. What's the takeaway for healthcare professionals? First of all, consent protects you, and you need to explain the risks. Even if common ones like post-operative stiffness occurs, you need to explain all the risks possible. Number two, document shared decision making thoroughly. Number three, not all poor outcomes equal malpractice. And number four, be clear that surgery is a best effort, not a guarantee of success. And this case really highlights the importance of communication, documentation, and setting realistic expectations. A general practitioner builds a close friendship with a longtime patient after her husband dies. They share house keys, and he visits regularly. Sometimes he even gives her medical care during these visits. Then the doctor's home is burglarized. He suspects the patient's daughter and cuts off the friendship and medical relationship. The patient ends up suing. There are three main accusations in this case. First of all, she sues for breach of confidentiality. She also sues for wrongful termination of care. And the last accusation is fraudulent billing. The disciplinary board rules the following. Confidentiality was breached. The doctor had shared personal information with his wife. Termination was lawful. The patient was advised to find a new GP and did so. Billing was also proper. No false claims were found. The doctor is formally reprimanded for the breach of trust. Takeaway for healthcare professionals. Number one, don't treat your patients as your friends. Don't become friends with your patients. Number two, confidentiality still applies even if it's outside the clinic. Number three, end patient relationships professionally and in writing. And number four, you need to maintain clear boundaries. No matter how close the connection feels, this is really important. This case is a cautionary tale about compassion, but boundary is very important. It protects everyone. A psychiatric nurse forms a close bond with a patient during his admission for addiction and mental health issues. Shortly after discharge, that bond turns into a secret romantic relationship. Weeks later, the relationship ends and the patient files a formal complaint. He accuses the nurse of emotional and sexual exploitation during a vulnerable period. The nurse claims the relationship only turned intimate after discharge and that it was consensual. But the disciplinary board sees it differently. They rule that the power imbalance still existed even after discharge and that the nurse had crossed ethical boundaries. She receives a formal reprimand. What are takeaways here for healthcare professionals? First of all, psychiatric patients are especially vulnerable even after discharge. Number two, power dynamics don't disappear when treatment ends. Number three, intimate relationships with former patients are often still unethical. And number four, new staff need supervision and clear training on boundary setting. In mental health care, blurred lines can quickly become serious violations, and professional boundaries protect both you and the patient. A security guard is injured at work. He's placed on medical leave, but just weeks later, the company doctor clears him to return. He still has pain. He objects. He goes back to work and struggles. And later, a second doctor confirms he wasn't ready to return to work. The employee files a complaint against the occupational health physician. He accuses her of three things. First of all, he claims that the medical assessment was poor. She shared medical details with his employee and delayed his eventual return. The employee files a complaint against the first occupational health physician. He accuses her of a few things: poor medical assessment, sharing medical details with his employer, and delaying his eventual return. The board is asked to investigate, and they find that the initial exam was appropriate given the available information. No confidential health details were improperly shared, only fitness for duty status. And the return to work delay was justifiable due to incomplete documentation from his treatment team, and so the complaint is dismissed. The main takeaways for healthcare professionals are: number one, occupational health involves dual loyalty to the patient and to the employer. Number two, confidentiality still applies. Only share what's necessary for work related decisions. Number three, always document your assessments and communication very clearly. And number four, patients can seek a second opinion and they should be informed of that right. In occupational medicine, clear boundaries and transparent communication are essential, especially when trust is on the line. A patient with bipolar disorder and psychosis is hospitalized after a manic episode and a serious incident. She refuses antipsychotic medication and later requests discharge, but the psychiatrist denies it, and she files a complaint. What are her claims? The psychiatrist failed to make an independent diagnosis, he coerced her into involuntary admission, and he violated her autonomy for forcing treatment. Well, the psychiatrist defends his actions and he says he reviewed her history, conducted his own assessment, and confirmed the diagnosis. He supported involuntary care due to psychosis and risk of harm. Antipsychotic treatment was necessary, and her improvement afterward confirmed the decision, and the board agrees. They find that the psychiatrist acted within professional standards. So, balancing autonomy with patient safety was important in this case, and the complaint is dismissed. What are the takeaways for healthcare professionals? First of all, patient autonomy is vital, but not absolute in the context of severe mental illness. Number two, involuntary treatment must be based on risks, diagnosis, and professional standards. Third, thorough documentation and independent assessment are key. Number four, always explain decisions clearly, even when patients resist. Respecting autonomy means more than just saying yes. It means making sure that patients are safe, making sure that ethical decisions are made in complex situations. A patient develops a dental abscess after a routine tooth extraction. He's referred to a maxillofacial surgeon who drains the abscess and starts antibiotics. But the infection worsens. A second drainage is performed, still no improvement. The surgeon leaves for a medical conference and the patient dies days later from complications. They filed a complaint that there was incomplete physical assessment, inadequate antibiotic choice, poor postoperatively communication, and failure to escalate care. The board agree, but they only partially agree. What they find is that a more thorough workup was needed early on. Antibiotics should have been escalated much sooner, communication with staff was insufficient, and the surgeon should have involved other specialists. So that surgeon was given a formal warning. What are the takeaways for healthcare professionals in this case? Number one, infections in the head and neck can escalate quickly, so you need to act early. Number two, don't rely solely on protocols, assess the whole picture. Number three, handover and communication are part of safe care. And number four, escalating treatment. It's not a failure, it's actually responsible care. And this case is a powerful reminder that standard care isn't enough if it doesn't fit the clinical situation. A patient with bipolar disorder and severe psychosis is admitted involuntarily after setting a fire during a delusional episode. She later files a complaint against a psychiatrist alleging he threatened her with forced admission, he ignored her physical complaints, he wasn't involved enough in her second admission, and he refused to transfer her to an open unit out of convenience. The psychiatrist explains he informed her of legal procedures. He didn't threaten her. Physical symptoms were examined and she was referred for further workup. He oversaw care through his team. It was a standard model of care in psychiatry, and the patient's ongoing psychosis and refusal for medication made an open unit unsafe. And in this case, the disciplinary board agrees. There was no wrongdoing found. The psychiatrist acted within ethical and professional standards. What are the takeaways for healthcare professionals in this case? First of all, explaining involuntary care isn't coercion, it's being transparent. Number two, physical health in psychiatric patients deserve full attention. Number three, delegation is valid as long as oversight is maintained. And fourthly, safety comes before comfort in high risk psychiatric care. Psychiatry often involves a complex, high stakes decision, and clear documentation can make all the difference. A patient suffers a neck injury in a car accident. An insurance medical advisor reviews the case and concludes it's a standard soft tissue strain. But over time, the patient develops chronic pain. Another doctor diagnoses whiplash associated disorder, WAD, a condition often invisible on scans. The patient files a complaint, claiming the insurance doctor failed to recognize WAD. He delayed sharing communication with the treating physician, compromising fairness. The doctor has to defend himself, and he says, well, his statement was based on available evidence and consistent with standard recovery timelines. And WAD is difficult to diagnose without objective findings. The communication delay was an oversight, corrected before the final report. The disciplinary board totally agrees with the physician. No evidence of negligence, no harm was done. Case dismissed. What are the takeaways for healthcare professionals in this case? First of all, subjective symptoms like pain must be taken seriously even without imaging proof. Number two, clear documentation of what you knew and when you knew it matters. Number three, communication delays can create mistrust, so try to fix them as soon as possible. Number four, medical advisors have the same ethical duties as those treating. This case reminds us small administrative errors can lead to big legal scrutiny, even when care is actually really good. A cardiologist reviews a patient's chest x ray after a minor stroke. He sees no issues and reports the findings as normal, but he hasn't read the radiologist's report. That report mentions a shadow near the aortic arch, and that report also recommends follow up. It's missed. 15 months later, the patient is diagnosed with stage 3A lung cancer. She files a complaint, and she claims the cardiologist failed to review the radiology report. He also delayed responding to a letter asking why it was overlooked. The doctor admits oversight and explains that the system didn't flag new reports at the time. He apologizes. The disciplinary board reviews the case, and what did they rule? Not reading the report was a breach of duty. The delayed response was unfortunate but not misconduct. The cardiologist was given a formal warning. What are the main takeaways for healthcare professionals? Number one, if you order a test, you're responsible for reading the full report. Number two, system errors don't excuse clinical accountability. Number three, follow up and follow through. These are non negotiable. Number four, patient communication matters, especially when outcomes are serious, and this case shows how one missed line in a report can change everything. A patient under long-term care for high cholesterol is prescribed simvastatin for several years. Her cholesterol improves, but years later she develops severe muscle weakness. A neurologist eventually diagnoses her with toxic myopathy, likely caused by statins. She files a complaint against her general practitioner, alleging she was never warned about side effects. The doctor delayed specialist referral, and the prescription was reissued after being told to stop the statin. And then the GP explains that statins were prescribed according to clinical guidelines. She investigated symptoms with labs and ruled out other cases. The reissued prescription was an administrative error, but it wasn't intentional. The disciplinary board rules that no failure in communication or care was seen, but that the prescription error warranted a formal warning. And so the general practitioner was given a formal warning. What are the takeaways for healthcare professionals? Number one, always document discussions on long-term medication risks. Number two, rare side effects still require patient education. Number three, prescription systems should include safeguards to avoid repeat errors. Number four, a minor mistake in practice management can still lead to formal consequences. And this case shows how communication and administrative precision are just as important as clinical judgment. A patient is diagnosed with erythema migrans, the classic rash of Lyme disease. Her general practitioner prescribes a 14-day course of doxycycline following the guidelines at that time. But the patient isn't satisfied. She asks for additional blood tests, including ones from another country, and longer antibiotics based on alternative protocols. The general practitioner declines, explaining that testing after treatment isn't standard unless symptoms persist. The patient continues to experience fatigue, headaches, and body pain. She feels dismissed and files a formal complaint. She alleges inadequate treatment for Lyme. She alleges also that the doctor refused to order further tests and that her symptoms were being dismissed. The disciplinary board reviews the case and they find that the treatment met national guidelines, further said the testing wasn't clinically indicated, and the GP had investigated ongoing symptoms and referred appropriately, so the complaint is dismissed. What are the takeaways for healthcare professionals? Number one, following national guidelines protects you, so document that clearly. Number two, patients often arrive with external advice. Listen to them, but make your decisions based on the evidence. Number three, communication is key. Explain why tests are or aren't done. And number four, acknowledge symptoms, even when you disagree with their cause. And this case highlights a common challenge a lot of doctors have, managing expectations without compromising clinical standards. An 89-year-old woman on long-term steroids for rheumatoid arthritis develops a blister on her leg after a minor fall. Her general practitioner opts not to open the wound and applies a bandage. It seems to heal. But weeks later, the area turns necrotic. The general practitioner refers her to a dermatologist, then things escalate. She becomes acutely ill one evening with fever, chills, a red inflamed leg. The general practitioner prescribes antibiotics over the phone and delays an in-person visit. By the time he arrives, the infection has advanced. She's hospitalized the next day and dies from sepsis. Her son, a doctor himself, files a complaint. The disciplinary board reviews the case and they find that the general practitioner delayed in-person evaluation in a high-risk patient. He acted to fail with sufficient urgency, especially given the vomiting, which may have affected the medication absorption. A formal reprimand is issued. What are the main takeaways for healthcare professionals in this case? Elderly patients on steroids are at high risk. Act early and in person. Phone consultations have limits. Know when to see the patient. Vomiting can impair antibiotic absorption. Don't overlook it. Infections in immunocompromised patients can deteriorate rapidly. A man in a care facility develops diabetic foot ulcer. An elderly man in a care facility develops diabetic foot ulcers. His general practitioner monitors the wounds, adjusts treatments, and works with the home care team. At first, things seem stable, but the wounds worsen over months. Eventually, the general practitioner refers him to a vascular surgeon. By then, it's too late. He's hospitalized, undergoes amputations, and dies weeks later. His wife files a complaint claiming the referral came too late, the general practitioner didn't ensure proper follow up, and he relied too heavily on the home care team. The disciplinary board agreed with the wife, and they find that the patient was high risk and required more direct oversight. They also find that early intervention might have changed the outcome and that the GP receives a formal warning. What are the takeaways for healthcare professionals in this case? Diabetic wounds require early aggressive management. Secondly, high risk patients need hands on follow up because deterioration can happen quickly, so delegation isn't enough. Number three, don't just give instructions, you need to verify that they've been followed up with. And four, document wound progression clearly and intervene sooner than later. In complex cases, being proactive saves lives, being passive invites risk. An anesthetist uses his medical training not to heal, but to harm. He disguises himself as a nurse, forges documents, and injects his mother's partner with a toxic substance. The victim suffers a devastating flesh-eating infection called necrotizing fasciitis and nearly dies. What was the motive? A deep-rooted family conflict and unresolved psychological issues. The doctor is caught by the police and charged. In court, the defense cites emotional trauma and distorted thinking, but the evidence tells a different story. It was premeditated, calculated, and medically orchestrated, and the court declares him a dangerous offender. He's sentenced to 31 years in prison and permanently stripped of his medical license. What are the main takeaways for health professionals in this case? Medical expertise is a privilege. Misusing it carries lifelong consequences, and it also puts the public at risk. Ethical violations don't just affect the patient, they damage public trust. Even in cases of mental illness, intentional harm is not an excuse. Professional identity can be lost permanently when boundaries are crossed. Now, this is a very rare case, but the message is universal. Medical knowledge must never be used as a weapon. A middle-aged man undergoes knee surgery for early arthritis. His surgeon uses a widely accepted implant at the time, but soon screws break and complications begin, and more surgeries follow. The implant is changed, donor bone is added, infections developed, and the surgeon tries repeated debridements, but nothing works. The patient eventually loses function in his knee and sues. He claims the surgeon used outdated methods, didn't remove all infected tissue, and failed to explain risks or show empathy. In court, expert testimony confirms the implant was standard at the time, and the surgical decisions, though unfortunate in outcome, were within accepted care. The surgeon is therefore claimed of negligence. What are the main takeaways for healthcare professionals? First of all, medicine evolves. Document the standard of care at the time of treatment. Number two, empathy isn't optional. Patients remember how they were treated, not just what was done. Number three, explain complications before they happen, especially in high-risk surgeries. And number four, when outcomes are poor, clear communication may be your strongest defense. And this case proves that doing the right thing clinically isn't always enough, and your words and presence also matter. A young patient visits the general practitioner with stomach pain. The GP suspects mild gastroenteritis, gives reassurance, and sends them home. But the child returns multiple times, and each time the symptoms evolve slightly more. First there's pain, then constipation, low-grade fever, and the parents grow frustrated. Eventually, the child is diagnosed at the hospital with appendicitis, and the parents file a complaint. They allege that the general practitioner dismissed their concerns, delayed a necessary referral, and didn't take pediatric pain seriously. The general practitioner defends the care. Each presentation had mild symptoms, no signs initially pointed to acute appendicitis, and advice and safety netting were always given at every visit. The disciplinary board reviews the case and they find no signs of negligence. The general practitioner acted within guidelines, but the case reflects how complex pediatric assessments can be. And the main takeaways for healthcare professional is that pediatric symptoms evolve fast, so reassess patterns, not just the moments. Document parental concerns and your reasoning for why you took a clinical decision. Provide strong safety netting advice and explain when to come back. Acknowledge uncertainty and involve parents as partners, not critics. And this case highlights how early symptoms can be misleading, but communication must never be one of the reasons why you don't take action. A patient with advanced cancer visits her GP repeatedly, showing signs of mental decline, confusion, and poor decision making. The GP wants to involve the home care service, but the patient refuses again and again and again. She insists on living alone and managing independently. Eventually, her condition worsens dramatically. She's hospitalized in critical condition and passes away shortly after. A family files a complaint and they argue the GP didn't act decisively, the GP failed to protect a vulnerable adult, and should have overridden the patient's refusal. The GP says the patient was legally competent at every visit, mental status was monitored, options were discussed repeatedly with documented refusal each time, and the disciplinary board agrees. There was no negligence, just a heartbreaking situation with limited legal tools. And takeaways for healthcare professionals. Competent adults have the right to refuse care, even if the risks are high. Number two, document every refusal thoroughly, including your concerns. Three, involve others, family members, social workers early on when capacity is borderline. Number four, respecting autonomy doesn't mean abandoning the patient, it means honoring their legal rights. And some outcomes can't be prevented, but being professional and documenting everything always matter. A young girl falls at the playground and injures her arm. Her father brings her to the general practitioner or GP the same day. The child can still hold a teddy bear and grab a pencil. No obvious pain. There's no swelling, there's no deformity. The GP suspects no fracture, advises watchful waiting, and says to return if symptoms worsen. But the pain persists. And 4 days later, the girl returns and still no major flags. The GP advises to monitor again. And weeks later, a different doctor orders an x ray and it confirms a green stick fracture. The father files a complaint arguing the GP should have ordered imaging earlier, his daughter suffered unnecessary pain, the follow up was inadequate. The court reviews the case. They find no negligence. The general practitioner's decision were clinically reasonable based on her initial presentation. However, the court emphasizes one key issue. Clearer follow-up instructions were needed. What are the main takeaways for healthcare professionals? First of all, green stick fractures in children often lack obvious signs, so don't rely only on function. Number two, when in doubt, explain your decision and what to watch for. Number three, language barriers can affect symptoms reporting. Always verify whether or not they understand what's expected of them. Number four, follow up isn't optional, it's part of self care. In this case, we find that kids are resilient, but their injuries deserve careful attention. And when you miss subtle signs, it's often due to communication, not just clinical skills that make a difference. A man recovering from vascular surgery begins to deteriorate. He becomes weak, short of breath, and fatigued. His wife brings him to see the general practitioner. The GP examines him, finds no signs of pneumonia, and suspects a mild viral illness. Antibiotics are prescribed as a precaution, but the wife isn't convinced. Later the same day, she brings him to a hospital. He's admitted with severe pneumonia, which is later confirmed to be Legionella. His condition worsens, he goes into respiratory failure, ends up in the ICU, and a very long recovery. He eventually dies more than a year later from related complications. His wife files a complaint, and she alleges that the GP failed to act on signs of deterioration, a pattern of underestimating chronic complaints, that the GP dismissed her advocacy. The court agrees partially. The GP should have referred him immediately based on the wife's concern, and post surgical patients with sudden decline require urgent review. A reprimand is issued for failing to act in the clinical context despite normal findings. What are the takeaways for healthcare professionals in this case? Trust your gut. Something's not right is a valid reason to refer. Number two, don't underestimate vague symptoms in post surgical or high risk patients. Number three, family input can reveal early signs of serious illness. And number four, Legionella and other atypical pneumonias require a high index of suspicion. This case reminds us clinical judgment isn't just about what you see, it's about what you sense.